So let's compare the condition because you know cervicitis and the acute serpingiophretus and the TOA and the chronic PID. First look at the symptom, then the pelvic examination, labs, and the management. In the symptom, you do not see any symptom in the cervicitis. You usually see the pelvic examination. You see there is mucopurulent cervical discharge, mucopurulent cervical discharge, and there is a culture positive for the gonorrhea or for the chlamydia. Okay, so you see the in the mucopurulent the cervical discharge. Okay, and you can check by the swab. So put the swab, you will see this discharge. Okay, so this is positive, and here you can see the chlamydial cervicitis. Okay, and you see the local the pelvic finding. Okay, the gonococcal cervicitis, chlamydial. Okay, and here is the urethral discharge. And what is the management for this condition? Azithromycin and the cefizine, once PU. Okay, and in the acute salpingo-operator, you see the bilateral pelvic pain because the bilateral, if it's a unilateral, it's suspected the ectopic pregnancy. In the bilateral, it's usually in the acute PID. Okay, so what are the other findings? Mucopurulent discharge, cervical motion tenderness, as I mentioned, so abdomen pelvic tenderness. Okay, so because of this inflammation in the tube. Okay, and you see the increased WBCs as I mentioned, and ultrasound with the normal limit culture positive, and the laparoscopy confirm the diagnosis. Okay, so this is laparoscopy, and you can see the adhesion and other thing of the acute PID. Okay, and the treatment, as I mentioned, outpatient or the hospitalized. Outpatient are which are diagnosed no systemic infection or pelvic abscess. So these are the outpatient. If the diagnosis is uncertain, the OP mean outpatient treatment is failed, and intrauterine device, abscess, and high fever. So these are considered as the hospitalized patient. So you know better, this is outpatient treatment, and here is the hospitalized patient treatment. Okay. So for the tubo-ovarian abscess, you see the severe bilateral pain, and nausea, vomiting, lower abdomen, pelvic, and back, and rectal tenderness you see usually. So these are considered, the pain is severe as compared to the acute PID. What you see in the pelvic examination, you see the bilateral adnexal mass and the septic look of the patient. If you see their face and eyes, so it's septic. Okay, and there is increased temperature, and but the blood pressure is low. Okay, and the peritoneal sign you will see, and you see the guarding. Guarding mean when you patient do not allow to touch the area. Okay, and there will be a rigidity. So these are the pelvic finding of the tubo-ovarian abscess, and there will be the culture positive for cervical and the blood culture, and WBC, ESR will be increased, and for the CT you see the bilateral complex pelvic masses. Okay, so you can see these are the pelvic masses, and here is you know better, this is the tubes, and here is you see the abscess. Okay, and in this picture you also can see these are the different tubo-ovarian abscess. Okay, so what is the management? Give the clindamycin and gentamicin. So it can be another option for hospitalized patient. Okay, and explore pericutaneous drainage is important. If there is no response after the clindamycin and gentamicin, so you should drain the pus. Okay. For the chronic PID, there will be chronic bilateral pain. Mean there chronic history of the bilateral pain, but you also they are present with the infertility, dyspareunia, mean painful urination, ectopic, or abnormal bleeding symptoms. What are your findings in the pelvic examination? You see the cervical motion tenderness, bilateral adnexal tenderness. Adnexal mean what? It's a part associated with the uterus, mean the fallopian tube, the ovaries, the peritoneum. Okay, so these are adnexal. When you touch this part, so this causes a tenderness. So there will be always bilateral. Okay, so this is the sign of the for the chronic PID, and you do not see the mucopurulent discharge, the the fever or BP, while in this case you are seeing the increased temperature, increased pulse, but low BP. But in this case, you do not find any change in this condition because it's a chronic. So what are the lab findings? You see the WBC, ESR or normal culture are negative. So you confirm by ultrasound. You can see the heterosalpinges, and you confirm by the laparoscopic. So heterosalpinges are what? So these are actually the lateral salpingitis, mean the tube mucous membrane is involved and there is some obstruction in the tube. So this is heterosalpinx. So other are the chronic PID condition is the pyosalpinx, mean pyo mean pus, and there is a purgative mean pus salpingitis plus obstruction. So this is known as pyosalpinx. So this other condition which is salpingitis asthenic nodosa, where you see the nodular thickness. Okay, so this is also a chronic type of PID, and here you also see the heterosalpinx mean where you see the cateral salpingitis. So this is also sit with the edema, so that's why there is hyperemia. Positive finding of the Doppler. So when you see the Doppler flow, so this represent the heterosalpinx. Okay, so here is also the show the heterosalpinx picture, and here you see them bilateral complex masses, tube ovarian abscess. You can see appreciate here. Okay, so these are different pictures. So here you see again the Doppler, so which confirm the hyperemia. So here is the pyosalpinx, mean pus formation here. Okay, so chronic PID types, heterosalpinx as I mentioned, so pyosalpinx, and the chronic interstitial salpingitis when there is thick fibrous wall and cutaneous lumen, the asthenic nodosa when there is nodular formation. Okay, and the tubo-ovarian cyst, which mean the heterosalpinx plus the ovarian cyst, and the tubo-ovarian abscess when there is pyosalpinx plus with the ovarian cyst, and there is chronic specific salpingitis which is the TB salpingitis. Okay, so these are the live findings. You confirm what is the condition, what is treatment option. Treatment option is the mild analgesia. Okay, so initially give mild analgesia to relieve the pain and the adhesion lysis, and but the actual treatment is the total the abdominal hysterectomy and with bilateral salpingo-oophorectomy. Okay, so you remove the uterus, you remove the fallopian tube, you remove the ovaries. Because we're removing all these structure, so give the estrogen replacement therapy. Okay, so these are the different type of the hysterectomy. So this is the total hysterectomy where you remove the uterus, and in this condition radical where you remove the extra part. But in this case, this is the condition total hysterectomy when you remove the uterus as well as the fallopian tube. But in this case we are removing the both, not single. So this is bilateral type. So this is the unilateral. So we are going for this condition. Okay, so these are different way of incision, vertical and the transverse. In this picture, you can see the uterus is removed as well as the both fallopian tube as well as the ovaries are removed. Okay, and this is the clinical picture of hysterectomy with bilateral oophorectomy. Okay, salpingo-oophorectomy. So these are different laparoscopic picture during the procedure. So this is a review chart of the PID, and these are the different clinical picture of the PID. Okay. Some keynotes. If you see the unilateral pelvic pain, it's ectopic. So if it's a bilateral, suspect the PID, and if the chlamydial infection causes the infertility, if the chronic PID, it causes chronic pelvic pain but no discharge, but there will be a infertility. Okay, so menstrual cycle association with PID. After the menstrual cycle, the mucous barrier breaks, so that's why the risk of PID increase. And these are roots of the PID. Okay, and here is the CDC criteria and causes gynecological as well as non-gynecological. So you should also rule out the differential diagnosis of the PID. Okay, so that's all about the PID. Thank you very much. Allah Hafiz.